So hot topics for today's nurse leader, and it follows along from this morning that all of you all are leaders, so these hot topics are for all of you, okay? So thinking about a little bit about what we want to just do in this space is just thinking about the 4 potential ethical areas. And if you didn't know these, and if I've thought it helped you think about that, that's good. I think what we're really dealing with right now within palliative care is physician-assisted death, palliative sedation, withholding and withdrawing technologies, and opioids at the end of life, and helping identify the HPNA position statements that support nursing practice in these areas. So, in terms of thinking about this, how many of you were at the annual assembly this year? Did anybody go to the town forum that we had on PAS? Okay. So for those of you who weren't there, the American Academy of Hospice and Palliative Medicine, National Hospice and Palliative Care Organization, and the Hospice and Palliative Nurses Association held a 90-minute forum on physician-assisted suicide, not from the perspective of whether it was right or wrong, but from the recognition that it's now in 5 states, and where do we go from? How are we supporting people in that? I can tell you that it was a very interesting process to plan it. Because, as you can imagine, it's a very hot topic, and people certainly have feelings about it, but we were sort of saying, we're sort of moved beyond that. In states where it is, what are we doing? And so some of the way that this session came out of sort of thinking about a dialogue about that. And, you know, language is really important these days, right? And if you kind of read the news or you read something else, you can sort of see coda for how things are. HPNA, just in terms of physician-assisted suicide, decided last October to pull the statement. And the board is really looking at this and sort of deciding what they're going to do. Now, as you can imagine, there are several different things. Some people are still using physician-assisted suicide language, but you could say physician-assisted death. You could say palliative sedation, which we know is not correct. But, you know, sort of people getting mixed up with that. We also know that for some people, withholding and withdrawing technology, they equate with hastening death, and then this whole opioids at the end of life. So we have this really fuzzy part of people not being able to distinguish it. That's the world we work in hospice and palliative care all the time, right? That this gray area. So I'm not focusing on voluntary active euthanasia or involuntary active euthanasia. That's beyond where we are. That is not legal in this country. But I think of really thinking about these are very intertwined, and although we may see these distinctions very clearly in our practice, the public does not perceive those nuances. And so you've got to really think about where we're coming from in terms of when we're working in states that have this versus thinking about our palliative sedation policies and looking at withholding and withdrawing of technology and opioids at the end of life. Now, the reason why I'm up here is more from a clinical practice. I am very aware that there are in this audience ethics experts and people who have done, you know, research on this more than I have. My real goal of this is to sort of think about a conversation, because as we move forward and thinking about how do we work through this as an organization and how do we help support you, there's some things that we need to know. So this is a map that's kind of important in terms of thinking about where we are just with assisted death. And so you have 5 states, Oregon, Montana, Vermont, what's that one? New Mexico has part of it, and this was before California. So we have 5 states, but look at all the states where legislation is being introduced. So we can pretend to put our head in the sand, but it's happening around it. Now, I'm in Massachusetts, and under the last election 2 years ago, assisted death was on the ballot, lost 49 to 51%. Now, we voted in cannabis, so my sense will be in our state, I have a feeling that next time it will pass. So it's an interesting thing to kind of think about of where we are. Now, the other part to think about is the way that this has happened. I was in Oregon when this first passed. I was part of writing policies and procedures for hospices about how we were going to deal with that, because I was on the Oregon Hospice Association. And then, so that went through the vote that way. Montana was through the legislature. Vermont was through the governor, right? So you have very different ways that it gets enacted, and so then you don't necessarily have processes in place. And that's what we heard in March from people in Montana, that this was passed and there was no policy or procedure of how to do this. And so one of the things that happened at the conference is we had one physician say, well, when people are talking about this, I just refer them to the compassion and dying people. That's an interesting process to have on your policy and procedure. You know, kind of thinking about where we're going with that. So this is also this data that we thought a lot of people were going to utilize this, and what this is this whole part that in fact played out. And having lived in Oregon, is anybody else here from Oregon? So Oregonians really don't like outsiders, and they don't like to be told what to do. And so, you know, what we really thought was this was about control. So you can see a lot of people ask for the prescriptions and get it, but they never really follow through. So it's, in fact, it's only been about like 1 to 5% of the population versus 50%. Now, I was actually intrigued because the woman from California, Brittany Maynard, when she said she was going to Oregon, I was a little surprised because when we started this, we had a residency requirement. So I'm curious if she must have had property there and was able to do that so quickly, because she hadn't been in Oregon for the 12-month requirement. But as you see, people are working around it and talking about it. So this is this public attitudes of when a person has a disease that cannot be cured and is living with severe pain, do you think doctors should or should not be allowed by law to assist the patient to commit suicide? So look at this percentage of people who think that they should be. 68% versus 28%. So whatever we feel, the public may have a different opinion. And so I think we have to pay attention to that. On the flip side of that, depending on where you live, for any of these procedures, if there's sort of a religious part of it, you know, that may be a whole different conversation. So really being aware of the cultural and religious aspects of where you live and where you work. Now, in terms of clinician responses, Betty Farrell did a study in 2000 of 300 nurses, and she found that they felt like euthanasia and assisted suicide is particularly significant to nurses because we're really trying to provide pain and symptom relief. And so this makes it harder to do our work. And so when you think about this, what happens to these nurses when they don't feel like they can do pain and symptom management? Yeah, this is moral distress. And my worry is, given the current climate with this opioid new CDC guidelines, you're going to see much more moral distress because people aren't able to get the medications, people are being weaned off. There might be hospice and palliative care teams who, in fact, are being asked to become opioid prescribers rather than pain and symptom. So there's a whole thing that you should think about with that. Then if we look at Belgium, there was a study there that said physicians consulted at least one nurse in 52% of end-of-life cases occurring in institutions, compared with 20% at home. So this means in the hospital, they talk more with nurses, but in the home, they may not necessarily think that the nurses would understand what's going on in the home. So that also is significant. And then I think this, Ezek Emanuel had done this study that at least in 2012, but I think this may be changing a little bit. For physicians, there's a tend toward the belief that physician-assisted death is not ethical, and that other professionals were split. Now, I also think that this is interesting, so you have to think about it in the sense that right now, the only people who've been able to write prescriptions is physicians. I know for myself as an APRN, there's a lot of discussion that advanced practice providers, so NPs, CNSs, and PAs, will be part of this prescription writing. And I don't know about you, but that really makes me pause and think of what my practice could change like with having to kind of think about it in a very different way. Because I think before, and happily so in my perspective, that nursing could say, we're here to relieve suffering, but we don't have an active part in writing any of these scripts. And as that changes, which it could, because in Canada this has now happened, and you could see it coming down, that may change the whole dynamic. So I think that, we're looking at some very interesting things that are happening with that. The other part that came out in '96, now things have changed, is sort of, in critical care nurses, this whole part about what happens in ICUs. What's the shades of gray? And I know that I experienced that in the ICU that I work up in the community hospital that I'm now in. So it's a 300-bed community hospital, one of the most underserved populations in Massachusetts. A lot of people under-resourced, underinsured. And I walk in the ICU and I think, wow, half of these people would not be in the ICU in downtown Boston. That's okay, but there's a whole different level of competence. So when people are on a ventilator from the ICU, there was no place in the hospital that they could go. They would go to the rehab floor of the rehab facility. I thought that was also interesting too, that we weren't teaching nurses how to do a vent. But when I went on the floor and I said, so how do we do a vent withdrawal? This is when I first started there. And they said, well, we don't have a policy. We just all do it how we feel like it. Now, you can imagine how I felt. I was like, ooh, this is just a disaster waiting to happen, right? And so when I went to tell that to the nursing director and the medical director, this is about leadership. Medical director says, well, we'll just write a policy and make people do it. That's not the way to go about doing this. You probably need to get a group together and really examine this and think about how you're going to do this. And then Betty Farrell and Pat Coyne and Marcia Grant and Rose Ronnie did this whole thing about beyond the Supreme Court nursing perspectives on end-of-life care. And again, it was this whole struggle about, when are we doing pain management? When does it cross over to hasten death? And many of us have had situations, I'm sure, where we have had nurse colleagues who are pretty heavy-handed with the opioids, and you're kind of wondering, and then other people who, won't give any at all. So, I think that struggle. And then Marian Mazzo, who is our director of research, also looked at oncology nursing and how are they responding to this. So this has been around for a long time, and many of us who have been practicing for a while also remember that these were pretty frank conversations when we had the AIDS crisis in the United States. Because if we pretend that it wasn't going on, they have it all over the internet of the ways that people can end their lives. So it's kind of naive for us to think that it can only be done by medicine. And then what happens with geriatric patients? How do they decide to end their lives? Stop eating and drinking. And so I know many hospices are struggling right now because you're getting patients who don't have a terminal diagnosis, but that people are saying, we want you to help them because they're going to stop eating and drinking. That's a really tough place to be, right? So we're kind of surrounded by these scenarios that, truth is stranger than fiction. If they made up a reality TV show, none of them would believe what we do every day. So that's why we, think about all these things. So the ANA has just revised Code of Ethics, and I know some of you may groan and say, God, why does she read those? Well, I'm always intrigued because this is where we're supposed to all practice from. And I think some of the things that they've modernized this, because this was just redone, are really something that we have to think about in terms of looking at these. So that we practice with compassion and respect for the inherent dignity, worth, and unique attributes of every person. I like that because it's not about us. It's about them. And how do we have to figure that out? And even if we don't agree with them, how do we kind of either guide them to other people who can talk to them about these issues or get them the resources they need? That we respect the patient's right to self-determination. We assist patients with decisions about resuscitation status, withholding and withdrawing life-sustaining therapies, foregoing nutrition, hydration, palliative care. I think that's interesting that gets put in there with that, and advanced directives. But I think this part about that, it's no longer okay for nurses to say it's not my job. Now, I don't think hospice and palliative nurses do that, but I can tell you I have a lot of nurses who say to me, I'm not going to talk about that. I don't mean to call out the state of Michigan, but I did some teaching up there for case managers, and there were some case managers in the back of the room who, after I did this whole thing on advanced care planning, raised their hand and said, we really have issue with what you've talked about today. And I'm like, whoa, because I'm thinking I talked about the least controversial thing possible. And they said, we think that you've gotten too much into psych diagnosis and psych care, and that's out of our scope of practice. I said, well, I thought this was about psychosocial care and really looking at values and beliefs. And they said, well, when you ask people about how they're feeling and what are they hoping for and what are their goals of therapy, that's pretty psych-oriented. I'm like, ooh, okay. So, You know, this is always a great learning experience for me about assumptions that I may have made about the nursing profession as a whole. So just think about that. Then the nurse should provide interventions to relieve pain and suffering in the dying patient with respect to evidence-based palliative care practice standards and may not act with the sole intent to end life. This is new, but I think this is really important and we need to build on it. We don't have as much evidence as we'd like, but they're really saying evidence-based palliative care practice standards. So where are our standards? HPNA has a lot of standards. A lot of you have developed standards. We have the NCP guidelines. So there's plenty of things out there. But then this sole intent to end life, you know, is really, I think, kind of helps guide us. So this is their new, they just updated this. That just came out last week, but this part was still kind of in consensus. End-of-life choices are a quality of life issue. Nurses have an obligation to provide compassionate end-of-life care. So I think this is, again, that we're really looking at these issues. And then the euthanasia, that prohibits nurses' participation in assisted suicide and euthanasia. So we're going to get into the same place if they make advanced practice providers be part of it, that it conflicts with our code of ethics. Now, you know, I think physicians have had the same thing for a long time with the AMA, but how we're going to do that. But then also this whole other part about providing humane, comprehensive, and compassionate care that respects the rights of patients. So this, again, gets us into this interesting part that in certain states they have the right to do that, and how do we work with them at that? So never dull. Again, in the assisted suicide, just so to have some perspective, HPNA reviews position statements every few years. Last year it was up for review, wrote a draft. The board sort of said, you know what, we're in a place that we just want to take it down and really look at it. The timeline is a little bit unclear, but I think that they're really trying to look at what all the issues are, think about what they're even going to call it, and think about then where's the membership. So, you know, when I think about where you all are, and you guys are great leaders for us, what are some of the things that you feel like we need to know if we're going to be updating the position statement to reflect your needs as members and your needs as nurses?
Yes? I've heard the term determined death.
Yep.
As the new language. Is that where we're going?
So I think that's a great point, Julie, of you know, because when you say a physician-assisted suicide, that has a little bit more of a connotation to it of self-determined death. And I don't know. I mean, I think that how we call it is going to say a lot for the organization. You know, the Academy of Hospice and Palliative Medicine, they've taken 3 years to struggle with this. NHPCO has been looking at this for a number of years, and I think all of them are looking at that and may be changing what their positions were. And the question is whether you come out and say you're neutral about it, or whether you come out and say you're against it. And that has a whole different set of ramifications, right? Because if you say you're neutral about it, then you're sort of like, how do you deal with patients? If you say you're against it, it may make it that the conversation is stopped. So I think what you're saying is, oops, that one doesn't like me. Let's try one. So terminology will be important, right, in the name. What else? Yeah.
The huge issue as a advanced practice nurse that I can't write a DNR and DNI. I cannot find a most or a post. However, then
Okay. Yep. So contradiction in scope, right? Yeah. Say again?
Just variations in the state legislators.
Yeah. Yeah, by state. What else? Yeah.
Well, I think when we've got standards of practice on end-of-life care, and yet we don't teach it in nursing schools, we've got a huge problem.
Okay.
And until this content gets on NCLEX and becomes a priority in the end part, we're not going to be making much progress.
Good point.
I
would say too, where does this fit into pediatrics?
Where the parents are making decisions, yeah.
Well, actually, if I think the more we're creating within our community technology-dependent kids, more and more stories are coming out of kids now electing, I don't want to keep my ventilator going, I want to keep my sustaining CPAP. So this change in wording to when hastened death is requested, that's, and they're not saying I want to commit suicide, they're saying I don't want the equipment anymore, and that's going to lead to their death. So
Yep.
again, about technology.
So, isn't there a big difference though between withdrawing aggressive life-sustaining interventions as opposed to this assisted death?
More what we've seen in pediatrics is a specific patient population of seizure patients who have consistent seizure activity, who are not being controlled by meds, that really cause their death, and parents wanting to know what are the options.
Okay. Other comments? I can't see you, so raise your hand so I can. Yeah.
So I think the word hasten death is wrong, and it's really untrue, because we do hasten death when we take them off the ventilator or stop dialysis. So what this is, the issue is, are we assisting death? This is not taking away technology. Everybody says, oh, we don't hasten death, but we do, because when we stop all these treatments, they die quicker. But I think when we talk about this type of role, it needs to be more clear that this is assisting death, or causing death, or, you know, I think we've done ourselves a disservice. It's not really true when we say we don't hasten death, because we do.
So you might say we're allowing death, right? Yeah. Right. Okay. So, right. And I think that's the thing, right? I mean, because I think that's the thing that we have to think about of why these policies have gotten sort of intertwined. I mean, you know, there may be some people that when, you know, we do palliative sedation for intractable symptoms, we're not trying to hasten their death, but we're putting them in a anesthetic state, right? So it'd be similar to like when you put them into anesthetic before surgery. But, you know, some of our policies, I have some colleagues in Switzerland who said, oh yeah, we do palliative sedation 3 or 4 times a week. And I'm like, let's have a little conversation about definitions. They're doing respite sedation versus palliative sedation. So people don't have to be a DNR and don't have to be at the end of the life, right? So being very kind of clear about that of, you're right, Peg, of terms of we do allow death sometimes by stopping things. So what does that mean? Yeah.
And there was a research presentation from, I think it was Belgium. A nurse presented, advanced practice nurse, talking about palliative sedation. Their definition of terms is different.
Yes.
Using morphine in the home, that's their definition of palliative sedation.
Yeah, so we've tried to get away from that.
It's really important to know that, because you have global conversation and you assume you're speaking the same language and you're not.
Yeah. Well, and so some of this also is not only thinking about how do we have position statements to help guide you. I mean, I think, you know, I kind of wonder how many of you actually have a policy and procedure for withdrawing and withholding therapies? Okay, well, not everybody. How many of you have policies for palliative sedation? Okay. And then how many of you are really doing opioids at the very end of life? So I guess what I would say to you is these are all, if we're saying in our mind we're clear about it, that's great, but other people are not. And in terms of having uniform processes, that's what gets us in trouble, right? And with patients and families, because I guess what I would throw out to you, and so one of the things we're doing beyond, think about beyond the position statement is, do we start having, we kind of put forth a guideline of procedural practices for people to adopt into their programs, because these are procedures and interventions, and you would not give blood without doing informed consent. So I'm constantly wondering why we do withdrawal of technology, palliative sedation, or sometimes very high-dose opioids without doing informed consent to tell families what the outcome could be, which we know is death, but they may not have really taken that in.
So we've talked about that, especially when we were developing our palliative sedation policy.
Yeah.
And even like with DNR, in our hospital, it's not a consent form that you sign to make your loved one a DNR, it's an order. So what we talked about, and kind of went back and forth, was really the family's perception of what they're doing, right? I mean, all of us in this room know what families tend to think, that they're pulling the plug, that they're the ones doing this, even though our recommendation is that we don't code your mom if she were, that we allow her to have a natural thing, that we, there's nothing further we can do to manage this disease process. We need to withdraw the ventilator. Signing something has a much different connotation than having a discussion, documenting it, and writing an order.
Well, it's a physician's order, it's kind of like when we did the I-post, you don't have someone witness a physician's order if we were ordering antibiotics. So we wouldn't do that to.
And we spend a lot of time convincing family that they are not killing their family, their wife, their mother, whatever. We spend a long time trying to make sure that this is allowing for a natural process, especially after we have those extensive goals of care discussion about what would this person want if they could sit up and they could tell us.
And if we have to say now, sign
we're asking them
here.
to sign. I think it's really going to put the onus back on them.
Well, I guess I would say, having been an organization that started it, it wasn't that bad. Because basically we're saying, this is the process, here's what we're going to do. There's a potential they could die from this. We just want you to know that. This is our goal, to make them comfortable. Are you okay with that? So they understand when we're giving these drugs and somebody else doesn't say, you let them give morphine, you let them give Haldol, what were you trying to do? Kill them? But we've had a process. So I think it's, when you start normalizing something, then it makes it not the exception. And so I just throw that out there for you because I think we understand this procedure, but I can't tell you the number of times, even when taking out a vent withdrawal and you have the family who said, show me your documentation of what you did because I think you just killed them. And we had no policy, no procedure, no process, and an informed consent. And so I will throw back, you wouldn't give blood, you wouldn't give a heparin drip, you wouldn't give other stuff without sort of doing this education and documenting. And we have to do that when we do opioids about when they're, that they shouldn't be driving or operating that or whatever. So why are we afraid to sort of do some of this? So I just throw that out of what's our fear about documenting that we had these conversations. Somebody in the back, and then I'll get back to you. Yeah.
So at the time that somebody's admitted to hospice, they're signing the consent about the various medications that you potentially might use. Is that what your organization is doing?
No, this was actually when we're doing that procedure itself. When we're planning to do it, and we're taking that time to say, this is what we're going to do, we walk the family through the whole procedure, what meds we're going to do, what's going to happen, who's going to be in the room doing whatever, and then, make a note, and then they sign a consent. I agree to palliative sedation to keep the patient comfortable. And then they have that piece of paper. Remember we talk about learning and education? They can actually refer back to it to understand what was done because we know that at that point they're not taking stuff in. So I'm just throwing it out there we're sort of in this interesting place where we believe in it, but then we sort of don't really want to talk about what we've done with it. So if we're saying that these are procedures that we want to do and that are hospice and palliative specialty pieces, we kind of need to own them a little bit. Absolutely. That's what I would also say, is it's a protection from you that the family can't say this was your intent, but you have this policy procedure. Yeah.
Yeah, are you willing to share your policy?
I'll have to see it because I'm not at the institution that I was at when we did it, so I have to see if they will let me do that. But I could give you some gist of it. Yeah.
Yeah, I think we advanced our practice and we got ahead of ourselves because that consent, it serves a lot of useful purposes, and one of them is to standardize the language across hospices. I had a situation about a month ago where I was called to do an admission for a 54-year-old female who was in a motorcycle accident. She was on a vent, and the hospital took her off the vent to harvest her organs. She, mother of three, the family was all gathered, and she didn't die. That's when they called us. So now I walk into this situation, and I get from the family, they treated us with kid gloves until she didn't die. And then they all walked away and called somebody from the out. It was really interesting. So there's always that possibility. I mean, she died within 24 hours, but in the interim, I had to call like 5 different departments to get somebody to put her on a morphine drip because she's not in the ER anymore. She's somebody else's. She's not on the floor. She's not ours. And it was terrible.
So you actually have brought up a whole nother piece that we won't do this year.
Take them off the bench, this may happen, or this may happen. So your bases are covered in a standardized way.
Right, but what I was going to say is the next part of that is even a policy and procedure for cardiac death, brain death, and for, what's the other one? Thank you. Because those are very controversial too in terms of the role of palliative care to be a part of that process. Yep.
We're actually doing something similar. We do have a number of terminal extubations, et cetera. We're using and putting them on inpatient GIP status with a hospice, with an outside hospice, and that's kind of where we're going with that.
So see, I mean, those are those interesting things about for hospices. If you thought home care, it's only where it's at, you have a great role in the hospital because some of these hospitals may be terrified about doing that, but with your expertise, you can help them do some of these policies and procedures. But how do we, as you've already said, have some standardization within the hospice and palliative care community so that we all can feel comfortable a little bit about what we're doing? Yeah.
So are you calling it palliative sedation when somebody's withdrawn from?
No. So I, in my own mind, and the way that HPNA, we have a very specific policy for withholding and withdrawing technology, which would be event withdrawal, G-tube withdrawal, withdrawal of pressors. Palliative sedation is when you have intractable symptoms and you have tried everything else and brought in everybody else and you can't treat it, so then you sedate that person, not to death, but to sedate them because if they're awake, they're more uncomfortable. So here would be the first time that we did palliative sedation in a big way was we had a 25-year-old who had cancer and he had pemphigoid characteristics in his throat, which meant that every time he was awake, he was choking to death. Now we couldn't treat the symptoms. We did all the meds and it was awful. And his mom was a nurse to boot. So we ended up having to put him to sleep because when he was awake, he was choking to death and we weren't going to trach him. That's palliative sedation. You know, withholding and withdrawing is that, you know, you have somebody on a vent and maybe they have ALS and they're now going to be dependent and they don't want it anymore. And so you are very deliberately and with a methodical process saying, okay, we're going to take them off the vent. We're giving them pre-medication. We'll do that and treat the family and have all that.
I just wasn't sure. I thought you were calling that
Yeah.
palliative sedation.
No. So that's why I'm saying we have policies for the HPNA for palliative sedation, withholding, withdrawing, opioids at the end of life. Many of you have helped write some of these policies. But then this one of whatever we're going to do with hastening death, you know, what is it that you guys sort of feel that you need from us to be either taking the policies and procedures that we have, or are there other conditions or ethical dilemmas that we have missed that you're needing us to respond to? Yeah.
One of the ethical dilemmas that comes up a lot in the cardiac world is deciding not to replace the battery in a defibrillator.
Oh, a defibrillator.
In a defibrillator.
Okay. Okay.
And I think going to the ownership and the comfort, it's such a polarizing argument with people who don't agree with hospice, palliative care, whatever, out of fear, out of just not knowing, and so on, that we should offer support to the folks that I'm not good at this, I'm going to introduce you to somebody who is, instead of just stopping the conversation, as you said, because that's what happens a lot. No, the battery needs to be replaced, we need to replace it. End of discussion. They're not really aware that there's this whole group they can talk to about, you know, what will happen if they don't replace it.
And so you're speaking to this cultural shift too. I mean, you know, I know that in the cardiac unit that I did, when we first said that we were going to turn off an AICD, they really thought that we were killing people. But, you know, this is the part about advocacy. I would really encourage your patients to talk about, like, wherever they're getting a device inserted, is that place of device comfortable turning it off or stopping it? Because, as you know, when you have a patient on a ventilator and you might send them to the vent hospital has no incentive to let them take off the vent, right? Or dialysis. So you got to make sure that you're helping match people up. But that's a great one, the AICD one. Yeah. The LVADs. Okay. All right.
It's not something that they can replace, and usually the hospital will not bill for replacement of that bag unless you want to pay for it yourself. But they
Mhm. Okay.
So the LVADs are difficult because they're going in and out of hospital, in and out of hospital. They're there all the time because every week they gotta have a lot of stuff done. And then at the end of their 5-year battery life, they're sitting there at the end and all of a sudden, that is not turning out.
Lisa, I'm gonna push you back. This is a transplant person. One of the things that we've done right in transplant is that we've set the standard that at the time a patient is evaluated for an LVAD, it's a mandatory palliative care consult.
Correct.
So, mandatory palliative care consult, we've got the foot in the door, but what we're not doing a good job with it is to get the message out. So, the palliative care team comes in and they talk to them about what the patient wants and then they sign off. That's the last conversation that's held. So every intervention down the road needs to be part of, have you had any changes in your medications? Have you thought any more about the discussions that you had with Dr. Smith regarding your end-of-life preferences? You know, we're just not supporting each other in transplant and hospice. So we've done some work. We've got the right support.
See, I'm on the hospice and they're not the palliative care end, and so whenever we get them, they're kind of, the hospitals haven't pushed for the palliative care units. It's almost like, well, they did their first initial talk with them, and then the palliative care team don't ever get to see them.
Or that's it.
They're lost, and then all the next time they go, well, you might need a hospice nurse now. Out in the field. And then there's not a lot of policies. There's some policies that they're working on. I've got Oshner, New Orleans, that has been working on. They've got their palliative care out inside the hospital for palliative care. There's not a lot outside for hospice nurses for guidance as to what I need to do with the LVADs at the very end, because they're not very long. And some of the medications make my nurses. When I have 8 nurses that just work in that one area, and they don't want to do it because they do feel like that they're about to kill somebody. They feel like they're going to go to jail and lose their nursing license because of that one thing for the LVADs. And so I'll say, we got an LVAD, it's like the room empty.
Well, so I'm going to bring it back because I think you had somebody here who talked about, you know, when we are thinking about this and we're bringing new people into hospice and palliative care, what is the orientation that we're doing for some of these ethical dilemmas? And so, you know, I'm going to frame it back to you in that sense that if we're going to do this well, we have to sort of ground first ethical principles that the nature of hospice and palliative care is laden with a lot of ethical dilemmas. I mean, we're stepping in to a place that people don't feel comfortable with, right? So really thinking about what your orientation is about the ethical dilemmas and walking people through some of these scenarios, because we're all going to get them, right? And what's the communication when patients sort of say to you, you know, I'm ready to die, right? And how do people assess that? Because they haven't said that they're suicidal. They're sort of saying, but you have some people who get nervous of like, oh my God, I'm like, wait, you have a whole communication session you actually need to do with a new nurse about, tell me what you mean, what's been going on, why are you asking that question, before you are calling the psych unit to say we're doing an involuntary admission. You know, so some of that part, and I think then also walking through, you know, clarity. This is why I'm saying policies and procedures, or thinking about case studies, and maybe that's what we need to help provide you with so you can adapt them, of what's a case study for palliative sedation in different areas, what's a case study for withholding and withdrawing care across some settings, you know, what's a case study for opiates at the end of life. That feels like it doesn't matter what setting you're in, it's still opiates at the end of life. But, you know, are there other things that we need to do to help you all keep nurses, because this can be really scary for that reason, that they think they're going to lose their job and people perceive them as killing patients. Yeah.
Also, depending on the setting, as you mentioned, if you are in an acute hospital inpatient setting where suddenly the patient declines and now it's a palliative and or hospice situation, which I know for us sometimes we'll have what we call a contract bed where it's a hospice patient, but they're too unstable to transfer. But that could sometimes last 24 hours, sometimes a week. So we're bound by the policies of our institution as well. Mm-hmm. So
sometimes the waters can get very muddy in that way.
So I'm sorry that we got shortened. I have to keep on time, so it's 2 o'clock. You have a full afternoon. Remember, there are concurrent sessions. Thank you. If you have other ideas or comments, please either email me or come talk to me. And have a great rest of the afternoon. Bye.